I'd like to welcome you to this session of the Center for Podiatric Education. In this session, I'd like to address the subject of wound care documentation. Many of us are now involved in wound care, whether it's diabetes or venous insufficiency or other wounds. There is no question that our practices have become inundated with patients with both acute and chronic wounds. These have become a major part of the practice of podiatry. And there are many aspects to documentation, including documentation for wound care, both medical as well as legal. When I look at the notes that I generate in the office, I think of these notes at three levels. After being in practice for 40 years, I realized that notes serve multiple purposes, and I think about all these purposes when I am generating the notes. Certainly, the primary reason that we generate notes is to record the medical care, and that is our evaluation and decision-making and treatment of the patient. Increasingly, we have concerns with regard to using our notes for regulatory compliance, whether it's Medicare or some third-party carrier. We know that our notes will frequently be requested for evaluation to look at the necessity for the services we've performed, to justify the performance of those procedures, our diagnosis, selection of therapies, and to verify that we did indeed perform those procedures for which we are billing. And then lastly, there's malpractice protection, and I can tell you that increasingly I am seeing plaintiffs' attorneys concentrate on the quality of records. Increasingly, they are looking at drop-down notes and pre-populated notes and errors that are made in the medical records, suggesting that these imply sloppy or poor care by the doctor. And it is very important, particularly when treating serious pathologies such as wounds, that we take all three aspects of these medical records seriously. Primarily the recording of the medical care we've rendered, the regulatory compliance aspects of this, and the fact that not every wound heals in a satisfactory manner. There will be some poor outcomes and less than satisfactory outcomes in treating these patients with wounds, and that we want to think about some attorney, some plaintiff's expert reviewing those records and looking for opportunities to criticize our care. And it's unfortunate that we have to think about maintaining our records in that fashion, but the fact is that we're seeing more and more publications out on how to look at your records and break them down and find fault with things and looking at inconsistencies. And even though you may have rendered perfect care, you're going to have attorneys sitting there going, well, you didn't write this and you didn't write that, and it doesn't say you told the patient this, and it doesn't say you told the patient that. So in the old days, it was easy for guys like me. We had the old paper charts and filing systems, and nowadays, of course, everything is electronic health records, and there's some days, particularly when the EHR system or your computer's perhaps not having its best day, that we kind of feel like that. A lot of it has to do with how you're trained, what you feel constitutes an adequate history and physical, Hopefully you're using some form of a SOAP note. We know that we can't possibly sit there and write every detail. It would just simply take too long. It's just not realistic. It's just not practical. It's been estimated that the average doctor at a minimum spends 2 hours per day just doing documentation. That for every 2 hours of patient care, 1 hour is spent just in performing documentation. And you don't want the documentation to take priority. I meet so many patients who tell me that they're speaking to the back of the head and neck and body of their doctor, who's turned around and facing their computer, entering their EMR system and not looking at the patient. And at times the patients come away with the feeling that the doctor is treating the computer and not treating them. And I think anyone listening to this can relate to that. We almost feel an urgency to get to the medical record to complete the complexities of the tasks involved in maintaining the record, rather than making our priority taking care of the patient. We have EMR systems that try to help us, and frankly at times make people lazy with drop-down notes and pre-populated notes and repeated notes. I think as we get older, we want our notes to actually be shorter. You feel like you've seen this a million times, and you know what the diagnosis is, and you know what you're going to do. On the other hand, third-party carriers want more and more detail, and they want longer and longer notes. Your system makes a difference too. If you're sitting there with a computer and you're typing the note, while it's inexpensive, it's kind of hard to focus on the patient. Voice recognition systems are good in many ways. They allow you to spend more time concentrating on the patient. You get instant feedback. But I think the real problem with voice recognition systems is accuracy. And of course there's the period of time for the system to learn to work with your voice. Scribes allow you to focus on the patient. However, there's a salary involved here and benefits, and the use of scribes is costly. And depending on your office size and income, it may simply not be practical to be able to hire a scribe. Paper charts makes you look antiquated. Submitting paper claims typically delays reimbursements to you. And it's a lot harder to share information between healthcare providers when you're working on paper charts. Looking at EHRs for a second, when people review charts, particularly attorneys, they always want to imply that record keeping is part of the standard of care, and they'll say, well, what's the purpose of medical records? And ultimately, the record is there to serve the patient and to serve the doctor. And what the doctor requires in their individual record-keeping methodology is really variable from doctor to doctor. We know that we want to have records available that will assist future healthcare providers in understanding prior findings, prior diagnoses, reasons for pursuing various therapeutic options. Again, unfortunately, we do want to think about the medical legal aspects when we chart and explaining things, so that if our decision making is questioned, that there's an understanding in that chart as to how we arrived at the conclusions and decision makings that we did. And again, for third-party reviewers and for so-called standard of care. From a more legal standpoint, documentation can be utilized as proof of fact that we did indeed perform certain services. It's a permanent record. It can be used increasingly with MIPS and so forth as for quality maintenance and improvement. My old professor, Dr. Ganley, used to point out that medical records can be used as an advertisement for your work. And I frequently think about the note that I'm sending back to that primary care physician, and I use that progress note as a chance to educate that doctor, to let them know what it is I do, how it is I'm evaluating that patient, how I've reached the conclusions that I have. And I try to educate that doctor not only about the patient's pathology, but also about the profession itself. Many don't have a real good understanding of what you know and what you do and what your capabilities are. And I think a good progress note is a wonderful way to advertise your practice and have a doctor understand what you're all about. From a strictly malpractice legal point of view, we've always heard document, 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 and we always hear if it's not documented, it's not done. And to some extent, it does put you at a disadvantage when documentation does not support your statements that you did indeed proceed with certain procedures and certain considerations. What should that note contain? Well, it's not going to be able to contain everything, but you certainly want to have the standards. Some of the things I think that are important to include would be the patient's medications and allergies and history of adverse drug reactions. You want to include the smoking status of the patient, past, present, and instructions to the patient regarding dealing with their use of tobacco products, particularly if you are treating them for a condition or performing a therapy with which smoking can interfere, so that it's important to tell patients undergoing surgery that smoking will interfere with their vascular supply, increase the likelihood of delayed healing, increase the risk of non-union of bone, slow down their wound healing, and make recommendations that they discontinue smoking. Note that the patients understood this conversation, and to repeat that to patients and document repeating that in future office visits. It's important to assess alcohol intake. Oftentimes we forget that even our older patients may be manifesting falls or neuropathy and other problems secondary to alcohol. If one is planning on immobilizing a patient or performing surgery, a history of DVT in the family or personally, a history of any blood clotting disorders would be important to review. A couple other things that I think are critical. Clinical findings, especially with wound healing. Oftentimes we see conflicts between drop-down notes from prior visits and the findings on a particular date. So you want to make sure that you're looking at any pre-populated notes, any drop-down notes, and make sure that they don't conflict with what you're writing for that day. It doesn't look good on examination when there's a disconcordance between clinical findings on a given date and what is dropped down from prior examinations. When laboratory studies are ordered, or x-rays are ordered, or vascular studies are ordered, it's important to note that you have reviewed those studies, that the results of those studies have been communicated to the patient when it's necessary to do so, and it's important to document what you're going to do with that information. Oftentimes errors are made because the right tests are ordered or the right x-rays are ordered, and yet there's no review of that data and no action taken. And this is very important in some areas such as biopsies. When we order consultations with other healthcare providers, it's important to note that the patient followed up with that consultation or did not follow up with that consultation, and that we've reviewed that consultation note, and here again what we're going to do with that information. And if patients fail to follow up with a referral for consultation, the patients need to be reinstructed to do so. Here again, it's important that your recommended plans at the completion of an examination is consistent with the diagnoses that are made. So we're in a day and age now where our assessment might include 4 or 5 different diagnoses, and we want to make sure that we are addressing each of those diagnoses with some type of plan, so that we're just not listing a diagnosis and not initiating therapy for those diagnoses, particularly when multiple diagnoses are present. For example, it might be a diabetic patient and they have skin xerosis and tinea pedis, they have onychomycosis, they have diabetic neuropathy, they may have a bunion deformity, and each of those risk factors requires assessment and then a treatment plan. So we may be initiating topical antifungal therapy. We may be debriding their nails to reduce the fungal load. We may be prescribing some type of therapy for their neuropathy. We might be recommending shoes to accommodate their bunion or hammer toe deformities. All these things should be listed and addressed to make the treatment look complete. With reference to medications, I think it's important to document why we've selected particular drugs, or conversely, why we are not utilizing particular medications. We may prescribe a more expensive topical anti-inflammatory because, for example, the patient may have renal dysfunction or hypertension or history of GI problems, or may be on an anticoagulant or some such thing. Or we may select certain medications because they're having significant pain. This is becoming increasingly important with the use of opioid analgesics, or medications that can have harmful side effects. You want to document the dosage you're prescribing, that you've discussed potential side effects with the patient, that you've instructed the patient to read the printed material which will accompany their prescription, and to call you with any questions or concerns, and that the patient has been directed to contact you or their primary care physician, or go to an emergency department or urgent care center should they have any adverse reaction to the medications. Your records should also document effectiveness of whatever therapies or medications you prescribed, the absence of side effects. For example, if you're using a tricyclic antidepressant for treating diabetic neuropathy, you might want to document the absence of fluid retention, palpitations, anticholinergic side effects, the absence of neuropsychiatric side effects. And then, of course, you want to document any modifications in therapy. If a patient is still not doing well, perhaps they're not responding as you would have liked, it's important to note that, and then to note what you're going to be doing, what you're going to be changing to modify that therapy. You have to be very, very careful with cloning and exploding notes. Third-party carriers are not particularly pleased when they see the same note over and over again. Medicare and other government agencies are not particularly thrilled with cloned notes and exploding notes, and in a malpractice case, plaintiffs' lawyers are using this increasingly to make it appear as though you are fraudulently generating notes that really did not reflect what happened on that particular visit, so that a cloned or exploded note looks great in one chart, but it looks terrible when they're lined up together. So be very, very careful of EMR, and don't be lazy, and give it some thought before dictating. Now let's get on to specific recommendations with regard to wound healing. And I want to address ulceration. It's important to have some classification system that you use. I think classically the Wagner classification system has been one that's been extremely popular. It's more of an anatomical classification. One could also use the National Pressure Ulcer Advisory Panel, which is very popular with nurses, PAs, and NPs doing wound care. When we talk about diabetic and venous ulcers, there's always the potential of an infection, so that in addition to using some type of anatomical classification, we also use an infection classification, and I use the Infectious Disease Society of America classification to speak to the infectious component of the ulceration. It is important to document the size of the ulceration from visit to visit in order to show that healing is progressing in a satisfactory manner. We want to describe the characteristics intralesionally of the ulcer, as well as the adjacent skin, foot and leg, and the presence or absence of any exposed fascia, tendon, or bone. So the Wagner classification is typically utilized. Other methods are to describe wounds as either partial or full thickness, or utilizing the staging system of the National Pressure Ulcer Advisory Panel. Any of these systems are felt to be acceptable. There are certainly other ulcer staging systems, but from an anatomical standpoint, it's, I think, a good idea to make reference to some accepted standard ulcer staging system. The Infectious Disease Society of America system includes 4 classes of ulcers: no infection, mild infection, moderate, or severe infection. And it's important to look at this classification system for several reasons. Number one is that it gives you a basis for not hospitalizing patients. It gives you a basis for not utilizing antibiotic therapy in certain individuals. So that, for example, in a mild infection with erythema less than 2 centimeters from the wound, a patient who's hemodynamically stable, whose glucose levels are not out of control, a patient, in other words, who's not sick, we can classify that patient as having a mild infection and not have to hospitalize that patient and have a basis to stand on. We could say that I'm following the recommendations of the Infectious Disease Society of America, and hospitalization was not mandated. So it's important to learn the characteristics that confer the classification of no infection, mild, moderate, or severe infection. Now, in addition to that, I go out of my way to also personally document the absence of indicators of infection, so that if I have a non-infected ulceration, I will document that they are IDSA, no clinical infection. I will document that there is no clinical evidence of sepsis. So I'll put down that there's no drainage or pus or exudate, there's no malodor, no erythema or cellulitis, no fluctuance or crepitus, no vesicle or bulla formation, and the absence of systemic signs of illness, and that their diabetes or hypertension remains under good control. These are all things that are important to show that you've looked at that entire patient, you've looked at that entire lower extremity, and you have a reasonable basis to suggest the patient was without infection. As far as measurements go, this is one means by which we can argue that the patient is improving under our care. We want to document the size, meaning the width, and the depth, and increasingly requirements are being made to document the volume of the ulceration. Looking at different criteria for progress, Medicare looks for reduction in ulcer size as 1 millimeter per week or 10% per month as an indication of appropriate progress. And of course, we've all heard wound care products being pushed on us as suggesting that we should have 50% reduction in size at 4 to 6 weeks. This is not consistent with Medicare criteria, which again is 10% reduction per month or 1 millimeter per week. You want to look for any undermining, tunneling, or sinus tract. And generally, when it comes to describing undermining or tunneling or a sinus tract, we use the clock system. So we say that there may be tunneling at 6 o'clock or 5 o'clock or 3 o'clock as you face the foot, so that we have a reference as to the location of that tunneling. Again, not only for other healthcare providers and third parties, but for ourselves to remind ourselves where it is that we had more difficult portions of the wound to address. Drainage, we know, does not necessarily imply infection, and patients sometimes will confuse any type of drainage as being suggestive of or representative of an infection. So it's important to document the type of drainage and the amount of drainage that's present. Generally, we can refer to the drainage as sanguinous or serosanguinous or serous, and they can be purulent, which can be infectious, or foul purulent or malodorous. So we want to use appropriate terminology to describe the presence of any drainage so that it doesn't appear as though we're being inattentive, because some wounds, of course, will suddenly turn, become worse, and we don't want the patient then thinking that we were ignoring their drainage. So it's important to document the type of drainage that's present. As far as drainage amount goes, there could be, of course, no drainage in a wound. It can be scant. And this system seems to be reasonable for describing the amount of drainage present. Is it less than 25% of the dressing? Is it between 25 and 75% of the dressing, or is it greater than 75% of the dressing? And here again, just as we document size, and hopefully the size is decreasing, we may be able to document also decreasing amounts of drainage based on the amount of the dressing that has been infiltrated by the drainage, as a reflection of improving conditions in the wound itself. You want to describe the characteristics of the wound bed tissue. Is the tissue that's present a non-viable tissue? Is it non-adherent? Is it loosely adherent? Or is it firmly adherent to the underlying ulcer bed? The type of tissue that's in the wound. You want to document not only the type, but the percentage. How much is slough? How much is eschar? How much is granulation tissue? Whether or not there is epithelialization, and whether or not there is any foreign body that is present. It's important to also look at the wound edges and include a description of that in your note. We can have well-defined or undefined wound edges. The wound edges may be rolled. They may be fibrotic, they may be macerated, they may be calloused, and you want to describe the general shape or geometry of those wound edges. It's important to document the appearance of the foot and tissues adjacent to the ulceration, and this would include the presence or absence of any discoloration or cellulitis or lymphangitic streaking, whether the tissues are indurated or firm, and the presence or absence of pain. We know that even in a neuropathic patient, pain can be present in a circumstance where infection is there. After we have evaluated the patient for their wound, administered appropriate care, our discharge plans should include our intended treatment for any pain, any home therapies or interventions that are going to be performed, and what our future plans are for evaluation of that patient. Now, looking at Medicare. When you are treating Medicare patients, we know that there's always the possibility of audit and review. And the question is, what would they be looking at in reviewing wound care charts? Well, we want services that are reasonable, so that you want that reviewer to come away from that chart saying, yes, that service was necessary. You want the services to be provided which are safe, and they should be effective, meaning that there is a response in the wound to your treatment which can be documented as being helpful. It should be furnished in an appropriate setting. Some Medicare carriers, for example, don't allow debridement of bone in the office setting, and the services should be provided by qualified personnel. Overall, the documentation should show that the wound is improving. Because it's not considered appropriate, it's considered in fact unreasonable and unnecessary to continue therapy if the patient is simply not improving. So your notes should demonstrate that indeed the patient is getting better. There are 4 basic components to documentation in the Medicare patient. There should be a certified plan of care. There should be documentation that the wound is progressing. If debridement is performed, there should be adequate records of that debridement. And the records should show that you're evaluating the patient generally and trying to manage contributing factors to that wound. Certified plan of care has 4 basic components: your treatment goals, a listing of complicating factors. This patient may be a dialysis patient. They may have poorly controlled diabetes. They may have a deformity that's increasing loading in some area. They may have vascular disease. So that the certified plan of care should include a recognition of these complicating factors and, of course, a discussion of how one's going to go about addressing these complicating factors. If debridement is going to be performed, why? And instead of bringing back patients every week or every 10 days or every 4 days, whatever, for a debridement as an automatic, realistically the record should show that you've evaluated that wound, you've looked at the patient on that examination and determined that based on your evaluation that day at that time, debridement was required, with a statement as to why that debridement is required. Removal of necrotic tissue, removal of fibrous tissue impeding epithelialization, whatever the case may be. And your certified plan of care should include recognition of patients who are not progressing well and looking at complicating factors, trying to assess why the patient is not responding and what your plans are to modify your treatment of that patient for that ulceration. Wound progress includes the wound volume, the presence or absence of any signs of infection, and whether there's devitalized, necrotic, or non-viable tissue. Debridement records are important. We frequently rely on debridement in an effort to help resolve wounds. Debridement is billed by the depth of the wound, and your record should include how deep the debridement was performed, not how deep the wound, but how deep the debridement. What method was used for debridement. the characteristics of the wound, the tissue that was removed, the appearance and size of the wound prior to and subsequent to that debridement, and your anticipated endpoint. And lastly, management of contributing factors. What are you doing about such things as offloading, correction of systemic factors such as diabetic control, anemia, nutritional considerations, and addressing whether or not the patient has been compliant. Most wound care recommendations include debridement, and there are many different ways to perform wound debridement. Debridement is by definition the removal of foreign or devitalized or contaminated material from the wound. This is generally considered appropriate in qualifying chronic wounds that are listed here that satisfy Medicare requirements for debridement. The coating should be appropriate for the depth of the wound that was debrided. Typically, this will include sharp debridement with or without anesthesia. There is also, of course, blunt debridement that can be performed. You want to remember that debridement alone is not sufficient to suggest that comprehensive wound management is ongoing. So again, even if the primary purpose for a particular visit is that for debridement, you want to address other factors that are operative in the hopeful resolution of the wound. Nutritional deficiencies, what is their vascular status, what are you doing about offloading, assessing the patient for any evidence of contamination or infection, that type of thing. Required documentation with regard to Medicare and debridement includes the type of debridement performed, the type of tissue that was removed, the level to which the tissue was removed, that is to say the depth, the instrumentation that was utilized for debridement, and again the appearance and measurement of the wound pre-debridement, the condition and measurement of the wound post-debridement, and a reassessment every 30 days regarding the progress of that wound. Lastly, I want to say a few words about deformities and the diabetic patient. Any podiatrist looking at this foot would say immediately, well, this is an easy one. The patient's diabetic, they're neuropathic, they had a hammer toe, they have an underlapping gray toe, and they developed a breakdown of the skin where one would usually develop a corn. And we know as podiatrists that many of the neuropathic ulcers we see, and certainly many of the neuroischemic ulcers, are based on deformities, structural and functional deformities. It was Sig Hansen that said quite some years ago that he did not agree that for these diabetic patients that shoes and pads and special devices to accommodate these deformities are the best approach. But he felt instead that early surgical intervention to correct these deformities was far more useful. And he related his experience in doing so for a number of years and felt that by reducing these deformities, he was able to reduce amputation rates rather substantially by as much as 80%. And this, of course, was provided that there was adequate vascular supply to heal. And it was his philosophy that foot deformities should be corrected early in patients that have diabetes, whether or not the deformity was related to the diabetes itself. And certainly all of us know that when we see these ulcers over hammer toes, over bunions, over Taylor's bunions, under metatarsal heads, that they are frequently associated with a very large structural component, and we wonder why we didn't intervene earlier and correct those deformities when the patient was younger and had more adequate vascular status. Of course, surgery on the diabetic patient is not without potential complications. So in looking at documentation in performing elective or semi-elective, non-urgent surgery in the patient with diabetes. It's important to document that the purpose of that surgery is prevention of ulceration, which can progress to more serious complications. These surgeries are more appropriate to perform when a deformity is rigid and non-yielding, making it less amenable to conservative care. We may be watching progressive deformities, perhaps secondary to a pronated foot structure, perhaps due to diabetic motor neuropathy. We have patients that have an explainable ulceration, meaning we know it's secondary to a bunion or a hammer toe or a hallux limitus with hyperextension of an interphalangeal joint. We can document that the patient has a chronic or recurring ulcer, that we've attempted accommodative and palliative care without success, and that it's a deformity in a patient with neuropathy. We know, of course, that there are potential complications in treating the diabetic patients surgically, and we want to follow some good protocols in terms of a reasonable hemoglobin A1C, assessing their vascular status, and generally checking on them systemically. But even so, we know that there are some complications that can occur more frequently in the patient with diabetes. So it's recommended that you document a strong indication for surgery. You document the adequacy of the vascular status, that you assess the patient for sensory, motor, and autonomic neuropathy, and document an understanding of the potential role of these neuropathic factors in healing. If there is an ulcer, you want to document the presence or absence of any infection, and certainly you want to document the status of their diabetes control and a general review of systems. What you don't want are records that make you look poorly. And I see this not uncommonly in reviewing malpractice cases, and it's an example of paying attention to what you've written before. So there's a note from a patient who's seeing a podiatrist to have toenail reduction. They're getting routine foot care, as they say. And in order to justify that foot care and justify Medicare payment, the note indicates that the patient has advanced skin changes with lack of hair growth, dry, shiny, textureless skin. Skin color is pale white tone with pallor, a blue, purple, mottled appearance, diminished pulses. Well, what we're saying here is this patient has significant small vessel disease, or seemingly does, and this is the reason they're going to be receiving Medicare support for routine foot care. Here's another note, the same patient, again advanced skin changes, lack of hair growth, smooth, dry, shiny, textureless skin, pale white tone with pallor, red, purple, mottled appearance, diminished pulses. So we're telling Medicare, here's the justification for cutting their nails. Here's another note on the same patient, a different visit, diminished pulses, bilateral, pale, cool, hairless skin, bilateral, with contracted digits. And you'll notice under diagnosis, their assessment is onychomycosis and arteriosclerosis obliterans. Okay, the patient comes back for another visit, and with all these notes attesting to the poor circulation, the doctor goes ahead and performs a flexor tenotomy on the plantar aspect of the second, third, and fourth toes, utilizing 8 cc's of lidocaine and marcaine with epinephrine. And of course, the patient ends up with gangrene and an amputation. Now, when you do something like this, and we see this regularly, you have conflicting notes. And how do you defend this? Do you say that you were committing Medicare fraud and the patient actually had decent circulation, so we should ignore everything that was written previously? Or do we just go in and say, I'm just plain stupid and operated on the top and bottom of a toe, we used epinephrine, in a patient with diabetes in whom I've documented arteriosclerosis obliterans and extremely bad circulation. But what you don't want is the toe ending up in a specimen jar with a pathology note like this. So be very careful in your documentation in the diabetic patient, and in fact any wound care patient, and make sure that your notes are consistent visit to visit. So in summary, I wanted to present some highlights on the documentation with patients who are being treated for ulceration. Hopefully this will give you a bit to think about. I thank you for your joining us for this session of Center